Hi, and welcome back once again. My name's Cam Mackay, and today we're going to talk about another fairly common surgical condition, and we're going to stay with the theme of hands for the moment for obvious reasons. Today we're going to talk about carpal tunnel syndrome. So let's get started. Where is the carpal tunnel? Well, if we do a bit of dissection on the presentation here, we can look at the palm of the hand and just go down one layer. Here we can see some of the muscles beginning to appear, and this structure here called the palmar aponeurosis. These fibres condense across the palm into the fingers and provide us some of our ability to be able to tense the palm and prepare for a grip. It's beneath this layer in here that we find the carpal tunnel. So it's right in the heel of the hand. We'll do another bit of dissection down one more layer. Here, down a little deeper, we see a structure called the transverse carpal ligament. Once again, located right in the heel of the hand. And this ligament forms the roof of the carpal tunnel. Passing underneath it already in this diagram, we can see the tendons to the fingers. We'll dissect down one more layer. Again, looking at the hand, and now we can see the nerves travelling and some of these tendons travelling underneath this transverse carpal ligament. And that space is the carpal tunnel. In a transverse section, so that's a cut across the wrist, and we're looking at the carpal tunnel and its contents. We can see the yellow structure there is the median nerve, and that's the nerve we're concerned about in this condition. Also within the tunnel are many of the flexor tendons, including all of the tendons to the fingers and the flexor tendon to the thumb. We can see in this picture that the carpal tunnel is bordered superiorly by the ligament, the retinaculum we saw just before. And on the floor of the carpal tunnel are the bones. From the radial or thumb side bones here to the ulnar side bones on the other side. Importantly, this retinaculum is a very strong structure. And it goes without saying that the bones and the ligamentous attachment of the bones are also very strong. So these tendons and the nerve are contained within a very strong anatomical structure. It's very rigid for a reason, but within that is some of the problem. That if for any reason the pressure within the carpal tunnel increases, and we'll discuss some of those reasons in a moment, the space can't expand, it's very rigid. And so the pressure increases within the carpal tunnel. And with an increased pressure, the softer structure is likely to be compressed. And in the case of the carpal tunnel, that's a structure called the median nerve. It's the compression on the median nerve that creates the symptoms. So what are the symptoms of carpal tunnel syndrome? Well, patients will often present reporting pain and numbness in the median nerve distribution. We'll discuss that distribution in a moment, but essentially it's the fingers on the thumb side of the hand. It's often reported as being worse at night, and patients will say that they wake at night with a numb hand. Often they'll report hanging the hand over the side of the bed to try and wake it up. It's often misconstrued as a vascular problem. So people will say, oh, I felt the blood supply had been blocked off and I needed to get the blood flowing again. So that waking at night with numbness in the hand is very common. This later progresses to more episodes of numbness during the day, often when doing very common activities, driving the car, talking on the phone, or reading a book. And you can see from all of those activities that the wrist is placed in an eccentric posture of either extension or flexion. So as the condition progresses, more of these activity-based and daytime symptoms develop. When it's more severe, weakness can start to develop in the hand muscles. And as the nerve supply gets more inhibited, the muscles can become weak. The symptoms will occasionally appear to involve the whole hand, though it's predominantly that thumb side or radial side of the hand. And like many things, there can be atypical presentations where it's difficult to tease out exactly what's going on. But as surgeons, we'll often suspect the median nerve because it is often the culprit. This diagram shows what we mean about the median nerve distribution of the hand. On one side here, we can see that transverse section of the carpal tunnel again, with the median nerve sitting within there and being squashed. As it's being squashed, traversing the ligament, the nerve, as it fans out to the fingers, is compromised. And so these radial 3 digits and 1/2 of the ring finger, which is a little interesting anatomical phenomenon, 1/2 of the ring finger can be affected. So this is the classical median nerve distribution. Another representation here shows the nerve within the carpal tunnel here being compressed and these radial side digits being affected. Again, 1/2 of the ring finger being that interesting median nerve distribution. Although, as we'll discuss in the advanced tutorial, that can be variable. How is it investigated? Well, nerve conduction studies are the first line treatment. These give us a quantification and qualification of what might be going on. The nerve conduction studies are performed by a neurologist and involve sending electrical stimuli across the nerve and assessing the transmission. This can tell the neurologist whether the nerve is compressed at the level of the wrist or elsewhere and the degree to which it's compressed. That's very important as we're performing surgery and monitoring the result of our surgery. Radiological investigations are rarely required. On occasions, your surgeon might perform an X-ray if they suspect arthritis or trauma. And very rarely we may do an MRI if a space-occupying lesion is thought to be involving the carpal tunnel and creating the compression. Other investigations like ultrasound are sometimes done to see if the nerve is flat, but are not particularly useful surgically. So that's what carpal tunnel is and how it might present. But what causes it? And there's a number of reasons. Again, we won't go into too much detail, but anything like actual direct trauma, degenerative arthritis within the bones of the wrist, and diabetes, obesity and pregnancy, all which involve more fluid in the soft tissue or more soft tissue around the area. This can all create that increase in the pressure within the tunnel. Interestingly, post-pregnancy, the condition can often resolve by itself. So pregnancy-related cases will generally be managed expectantly and less severe. The relationship of carpal tunnel to work-related activity is highly controversial, but intuitively, the wrong activity done enough or a very forceful or traumatic activity can irritate the nerve in this area. So we need to be careful about how we treat our hands and aware that it can happen in a work environment. This can be direct trauma or poor posture and direct pressure over the nerve. It can also be intense vibration or performing highly repetitive activities with which we're unfamiliar. How is carpal tunnel managed? Well, like any surgical condition, we have to consider if we can manage it conservatively. That means without surgery. Then there are surgical options, which will resolve the problem altogether, but involve the risks of surgery, and we'd like to avoid that if we can. The first part of conservative management is to just rest the hand and stop the aggravating activity. If we can do that, the condition may have a chance to resolve. A nice addition to this is a splint at night to keep the wrist nice and straight and prevent the aggravating and exaggerated postures. In general, it will happen at night because we're sleeping in a flexed position. With a nice soft splint on in the evening, such as this one, we can get some more rest as the nerve is not being compressed and causing us to wake up. The splint can also be worn during the day if required. Some therapy and massage and other therapies involving heat and ultrasound and occasionally acupuncture can all help relax the area and give the nerve more space and a chance to recover. More invasive things like steroid injection can be considered, but are often only used once, often in the atypical cases, or sometimes in the pregnancy situation where we're trying to just get past the delivery of bub. Steroid injection can also be useful in a very atypical case where we're not sure if the carpal tunnel is to blame. A positive result from the injection can clinch the answer for us. Medications can be useful, but only in the very short term would we use an anti-inflammatory. If the symptoms are persisting, we should do something more permanent. From the surgical point of view, there's really two options: an open carpal tunnel or an endoscopic or keyhole carpal tunnel procedure. And we'll go into the details of the operation more in the advanced tutorial. Needless to say, the open carpal tunnel involves a larger cut across the heel of the hand, and the endoscopic involves one or two small cuts in remote positions, and the surgery is then done with a telescope from the inside out. In essence, though, the goal of surgery is to release the flexor retinaculum to give the nerve more space. By releasing the retinaculum and allowing everything to expand, the nerve has got more ability to sit comfortably within the carpal tunnel and not be compressed. Therefore, the nerve fibres are able to normally transmit and the symptoms resolve. So that's a quick summary of carpal tunnel on a basic level. I'll shortly be doing an advanced tutorial for those that want to know more. And if you have any questions, please let me know, because I'd love to talk more about carpal tunnel if it'll be useful to you. Thanks again. See you soon.